Thank you.
Okay, thank you. Hello, everyone. I'm Dr. Han from Beijing Arion Cancer Center. I'm a physician. Today, I will share with you precision treatment of colorectal cancer guided by NGS. First, let's take a look at the application of genetic testing in the treatment of colorectal cancer. Let's refer the NCCN guidelines for colorectal cancer. The guidelines clearly recommend testing the status of three genes, KRAS, NRAS, and BRAF, to guide the selection of target therapies. The guidelines also recommended testing microsatellite status if the result is dMMR or MSI-H. Immunotherapy is the first line option. Additionally, the guidelines suggest detecting several rare targets, including HER2, NTRK, POE, POD1, and RET. The CRYSTAL-1 study has brought hope for benefit to CRC patients with KRAS G12C mutation. Among adagrasib monotherapy group, the ORR was 22% and DCR was 87%, while adagrasib plus cetuximab target treatment group, the ORR was 43% and the DCR reached 100%. So FDA granted accelerated approval to adagrasib in combination with cetuximab for adult patients with KRAS G12C mutated locally advanced for metastatic colorectal cancer. Many studies have confirmed that patients with advanced colorectal cancer featuring dMMR or MSI-H, both single-agent immunotherapy and dual immunotherapy can bring long-term benefits compared with chemotherapy combined with target therapy, with significant prolongation of PFS and OS. Similarly, the new adjuvant treatment of early-stage resectable dMMR or MSI-H colorectal cancer, immunotherapy, especially dual immunotherapy, has achieved especially high PCR rate. For HER2-positive colorectal cancer, multiple studies have verified the efficacy of anti-HER2 therapies. Especially, the median OS was 24 months in patients treated with trastuzumab plus tucatinib, versus 13 months with DDXD. These findings underscore the importance of HER2 testing in clinical practice. About 10 to 30% of colorectal cancer show familial aggregating, with 5 to 6% linked to hereditary syndromes. CISCO guidelines recommended checking all patients of tumor family history and in testing all patients for tumor family history and intestinal polyps. Eligible ones need further genetic screening. Multiple gene mutations are confirmed to related to hereditary colorectal cancer. Genetic testing identifies high-risk individuals, guide preventive care, and enable early prevention, diagnosis, and treatment to benefit for more people. Lynch syndrome, the most common hereditary. Oh, sorry. Lynch syndrome, the most common hereditary syndrome linked to colorectal cancer, accounts for about 5% of all cases. Caused by germline mutation is mismatched repair genes. It correlates with favorable immunotherapy response. Accurate clinical identification of this patient is crucial for improving outcomes. Genetic testing can help us evaluate patients' prognosis. Previous studies have shown that MSI-H high is a favorable prognostic marker, while BRAF mutation indicates poor prognosis. The general prognostic hierarchy is as follows. In addition, a study published in 2019 demonstrated that ZZ patients with MED4 deletion have significantly reduced recurrence-free survival. Thus, MED4 deletion is also recognized as one of the markers of poor prognosis. The NCCN colon cancer guidelines note that ctDNA is being studied as a marker of evaluated recurrence risk in stage 1 to 3 colon cancer. Dynamic trial enrolled stage 2 colon cancer patients, evaluating if ctDNA-guided management could reduce adjuvant chemotherapy without raising recurrence risk. Experimental group patients underwent post-operative ctDNA testing at week 4 and 7. ctDNA-positive patients received chemotherapy, while negative ones were exempt. The primary endpoint was the 24-month RFS rate between two groups. The study results showed that ctDNA-guided group received less adjuvant chemotherapy than the standard group, with no significant difference in 2-year RFS rate. In the ctDNA-guided arm, positive ctDNA results at week 4 or week 7 were identified as poor prognostic factors. This finding suggests that positive post-operative ctDNA is also one of the markers of poor prognosis. 2 post-operative ctDNA tests enable nearly half of the patients to avoid adjuvant chemotherapy. This approach may truly distinguish high-risk from low-risk patients, sparing low-risk individuals from unnecessary chemotherapy. Next, I will share 2 cases to illustrate the application of NGS in clinical practice. Case 1, a 37-year-old male with ECOG 0. He was diagnosed with rectal cancer and liver metastasis in November 2019. He underwent radical resection of rectal cancer plus open liver tumor resection and RFA, stage 4 dMMR, KRAS, NRAS, BRAF, and PI3Ka wild type, germline MSI-H2 mutation, MSI-H high, and TMB high. No family history of cancer was reported. The patient was identified with a likely pathogenic variant of MSI-H2, suggesting a high risk of Lynch syndrome. Based on the Keynote 016 clinical study, we selected pembrolizumab monotherapy. Unfortunately, the liver metastasis progressed significantly after 2 cycles. We reviewed the patient's genetic testing report again and identified a frame shift mutation in SOX1. SOX1 mutations abnormally enhanced its negative regulatory function, excessively suppress the JAK state pathway, block IFN gamma-mediated anti-tumor immune signaling, and upregulate PD-L1. As a result, immunocheckpoint inhibitor failed to activate to T cells to kill tumor cells, ultimately leading to drug resistance. Therefore, the SOX1 mutation in this patient may be one of the reasons for the poor response to immunotherapy. We supplemented the microenvironment detection of the patient's tumor tissue. ICS results showed that both intra and pre-tumoral lymphocytes expressed PD-L1 to varying degrees, with CD4 positive and CD8 positive T cell infiltration in the pre-tumoral area. However, almost no CD8 positive cells were detected inside the tumor, meaning effector T cells failed to infiltrate the tumor tissue and exert anti-tumor cytotoxic effects. How can we improve the tumor immune microenvironment? Studies have shown that anti-angiogenic agents can synergize with PD-1 inhibitors to enhance efficiency. Anti-angiogenic drugs can remodel tumor blood vessels, ameliorate the immunosuppressed state of the tumor microenvironment, and promote T cell infiltration. Meanwhile, immunocheckpoint inhibitors can activate T cell to kill tumor cells. The combination of two exert a synergistic anti-tumor effect. For the second-line therapy, we selected the combination of pembrolizumab plus bevacizumab plus cetuximab for 6 cycles, followed by maintenance therapy with pembrolizumab plus bevacizumab. The patient achieved completely response after 2 cycles and has maintained CR ever since. Case 2, a 50-year-old female with ECOG1. He was diagnosed with transverse colon cancer with multiple retroperitoneal lymph node metastasis in June 2020. He underwent palliative bite hemicolectomy stage 4 dMMR, and the patient's father had a history of colon cancer. First-line therapy, bevacizumab plus cetuximab for 3 cycles. Unfortunately, imaging examination revealed the occurrence of multiple new metastases. We performed genetic testing on patient, and the results showed a polymissense mutation. MSI-H high was not detected, TMB high. Let us first understand the POE gene. Its nuclease domain has proofreading activity, which can recognize and correct mismatched bases generated during DNA replication. Pathogenic mutation in the POE X nuclease domain are mostly associated with TMB high. When POE is mutated, its proofreading function is lost, leading to hypermutation burden. These mutations are mainly based substitutions, thereby increasing the generation of new antigens. Meanwhile, POE mutation colorectal cancer exhibits an active immunoenvironment similar to MSI-H high patient, which is mainly characterized by increased CD8 positive T cell infiltration, upregulated expression of cytotoxic T cell effector molecules, and high expression of immune checkpoints. Let's look at the relationship among POE, MSI, and TMB. MSI can only partially explain TMB high. Inactivating mutations in the POE gene are associated with TMB high, and their impact on TMB is even greater than that of MSI-H high. Key takeaway: for guiding immunotherapy, TMB, MSI, and POE should be tested simultaneously. Therefore, for this patient, we selected second-line therapy with sintilimab plus bevacizumab plus irinotecan plus rituximab for 7 cycles, followed by maintenance therapy with bevacizumab plus sintilimab. The patient achieved PR after 2 cycles and CR after 4 cycles, and has maintained the CR ever since. These 2 cases fully demonstrate the importance of NGS testing in the treatment of advanced colon cancer. Based on different genetic profiles and molecular subtypes, we selected precise treatment regimens for the patients, enabling them to achieve long-term survival. Finally, let's explore the application of novel testing technologies in colorectal cancer. Transcriptome sequencing as a novel detection method has shown great potential in the treatment of solid tumors. Common types of transcriptome sequencing include bulk RNA sequencing, single-cell RNA sequencing, and spatial transcriptome sequencing. First, let's talk about bulk transcriptomic application. A study identified over 2,000 immune and inflammation-related genes by doing transcriptome sequencing and differential gene analysis on different metastasis lesions of uveal melanoma. Based on these genes, they developed the uveal melanoma immune genomic score. This score can predict the anti-tumor efficacy of extra vivo expanded TILs, providing a predictive marker for TIL therapy. Single-cell RNA sequencing is also used in clinical research. A study confirmed via pre- and post-immuno checkpoint inhibitor single-cell transcriptome analysis that immune checkpoint inhibitor remodel renal cell carcinoma's tumor microenvironment and alt tumor immune cells interactions, key for assessing immune checkpoint inhibitor responses and resistance. Going forward, single-cell sequencing will help explore immunotherapy-resistant mechanisms and identify new therapeutic targets. A study used spatial transcriptome sequencing to predict new adjuvant therapy efficacy in HER2-positive breast cancer. These are some examples for transcriptome sequencing applications in solid tumors. This technology can also be applied to colorectal cancer, offering new insights for predicting treatment efficacy and evaluating prognosis. Professor Sun's team has achieved preliminary results in developing a transcriptome-based model to predict leptin efficacy. We hope transcriptome sequencing can be translated into clinical practice soon to benefit more people. Testing for Finally, to summarize today's presentation, NCCN and CISCO guidelines mandated NGS testing for all colorectal cancer patients to guide targeted therapy and maximize survival benefits. Genetic screening and risk management for pathogenic genes linked to hereditary colorectal cancer syndromes enable early prevention, diagnosis, and treatment. Benefit affect families. ctDNA or MRD testing aids in predicting recurrence risk for stage 1 to 3 colon cancer, with more MRD-guided treatment study underway. As an emerging genetic testing tool, transcriptome sequencing holds substantial potential for predicting treatment efficacy, and investigating drug resistant and mechanism. That concludes my presentation today. I hope that precision treatment of colorectal cancer guided by NGS can bring more survival benefits to patients. Thank you.
Thank you so much. Thank you. Appreciate it, Dr. Han. It's really a great another third talk in our webinar. We start with medicine, then we start with the surgical, and we end with the precision oncology. It's really a good structure program from Dr. Muhammad and his team. I learn a lot, to be honest with you. I'm pretty sure that the 200 plus attendee, they learn a lot. My question to you, Dr. Han, is regarding the turnaround in the NGS. In my hospital, it will take up to 4 weeks to get the results. So I'm not sure in the Arion Cancer Center, it will take how many weeks usually to get the results of the NGS? 2, 3, 4, 5, 6 weeks, less or more?
Oh, thank you. The NGS result in Arion Cancer Center is maybe 1 week. We can get the result in 1 week.
Excellent. The tissue as well as the blood.
Both the tissue and the blood.
Amazing, amazing. To be honest with you, I thought we have a big step in my hospital because recently, in the last year, we start to get the result of 4 weeks, and I was impressive. However, I'm so impressive and envy you and Iron Cancer Center that you get the result within 1 week because honestly, this is not luxury. This is a standard of care to get the result of the NGS to guide the therapy, either to right or the left, to choose this or that. So it's excellent. My last question, and again, if any one of the attendee, just raise your hand to ask a question for our expert. My last question to you, Dr. Han, is do you usually get NGS specific for the colon, NGS specific for the breast, NGS for the breast? Because when I sit with our molecular pathologist, he said that you have an option either to get comprehensive NGS that you tackle a lot of genes, 200 plus, or you just focus about which cancer site your patient have a colon cancer. Okay, we will tackle 20 gene or so. We want to look for those targetable mutation. So I'm not sure in your practice and your preference to have comprehensive NGS regardless of the cancer site, or you want to tackle NGS for the specific. If your patient is a colon, no, I want the NGS specific for the colon.
Thank you. In my opinion, I hope my patients to get the NGS for more than 500 genes because it can help us to understand why the chemotherapy or the target therapy can't work. Maybe give us more and more information. If the patient have some economic has some problem with the economic, and I will suggest him to detect the special gene. That's all. Thank you.
Absolutely. Thank you so much. I totally agree with you and echo your thoughts. I prefer personally to have the comprehensive NGS to help this patient as well as you may detect something in the future the patient need, especially in the metastatic setting, as well as to help his family if the family needs screening. So the comprehensive NGS is way benefits, in my opinion, similar to your input compared to the specific NGS. Thank you so much for our great